This conference will now be recorded.
Thank you, Laura. Laura is in our office in Chicago. We currently have people literally coast to coast on this call. Welcome, everybody, to our Fireside Chat, Patient Advisors in Pandemics. We have combined today the Consumers Advancing Patient Safety Advisory Panel and the CoMagin Health Patient and Family Advisory Council. And there are just a couple of people who are on both, but I consider you all to be great friends, and I really appreciate you taking the time to join us today. We are joined today.
Lisa, you just muted your microphone.
Lisa, we can't hear you, just so you know.
You're muted, Lisa.
There, is that better?
Hey!
See, Morris, technical stuff. I'm probably going to catch you, buddy. I wanted to say thank you so much to everybody for joining us. And if you didn't catch it before, we have Joan Gallegos, and we have you were joining us from CoMagin. And just to give everybody an idea of what we are talking about here, Consumers Advancing Patient Safety is a national organization, and this is our mission statement. I won't take the time to read the whole thing, but we partner with both patient advocates and providers all over the country with a goal specifically of creating safe environments in healthcare. Joan, do you want to explain CoMagin Health? Joan is the executive director of CoMagin.
Yes, thank you. And, we're getting some background feedback. If you're not speaking, please mute your line. I'm getting quite a bit of feedback for some reason. Thank you. I think that's better. CoMagin Health is our quality improvement organization for 6 states. Every state has a quality improvement organization. We have large Medicare contracts. We work with providers at all kinds of settings. And as Lisa has been so kind to put up our mission statement, we have very lofty goals. We really are trying to create a better healthcare system. So providers, patients, and our citizens will flourish. And one of our key initiatives, because we can't accomplish this mission without valued input from our patients and families. And I'm so proud of our Patient Family Advisory Council. They just do wonderful work and keep us on the straight and narrow. So we're hitting the nail on the head with our healthcare. So you're going to hear from some of them today. So thanks. I'll turn the baton back to you, Lisa.
Thanks so much, Joan. And Joan does amazing work. Really appreciate her. So we've already done the welcome and talked a little bit about CAPS and CoMagin. We're going today to look at the impact of this pandemic on behavioral health and mental health and provide some resources. This is being recorded and will be available on the CAPS website and will be made available to Joan at CoMagin to share with that advisory council so that you can get those resources. We can also send them out in a hard copy. We're going to ask what we can do. What can we do sitting at home as patient advisors at this time? And then address some other issues and recommendations and look at next steps going forward. So the first thing we're going to do is look at the impact of COVID-19 on behavioral health. And we're going to turn the time to our friend Kimberly Mueller from CoMagine. Kimberly?
Okay, am I unmuted?
You are, you're great.
Perfect. Okay, thank you. So thank you. I'm really honored to be here with you today. Really looking forward to your input and your insights on this circumstance, because I think this is something that's impacting every one of us in some unique ways. So I really welcome the opportunity to be part of the conversation today. What I wanted to kind of just start off with was talking about social isolation and loneliness, which has been already a major problem in our communities even before COVID-19, and especially with older adults, which is a population that CoMagine Health really focuses on quite a bit. I've seen estimates in the neighborhood of about 40% of our nation's seniors reporting loneliness, and again, this was before COVID-19. So there's growing concern about the mental health impacts of this pandemic, and it's stretching the coping and the resilience of our population, inclusive of, but not limited to, our senior populations. And it's more poignant for our senior populations because many of their structural support systems, like organized meals and activities at senior centers and opportunities for socialization and visiting with families, those are all greatly inhibited by the requirements for social distancing, which isn't a term I'm a huge fan of because I think it's actually physical distancing de facto, and it's, the artifact of that is that we're socially distanced, and so that just puts us at a greater disadvantage in mobilizing what our typical resources would be available to help us. So I think in general, we're seeing a lot of warning signs across the board in terms of increased requests for assistance. In Utah, for example, we're hearing that there are greater requests or greater calls for domestic violence coming into authorities, which is quite concerning. And so I think the interruption of our regular and comfort-inducing routines is depleting our resources. And as we're facing a new and a really significant stressor, which is really quite concerning. So some of the things that we have been doing at CoMagine Health is to try to help, for example, identify what local organizations, mental health care organizations, have providers that are enabled to see clients with mental health needs through telehealth. That's something that has not really been highly available, I think, in our communities up until now. There are pockets of innovation out there, but the decrease in regulations and restrictions on accessing those services has meant more people are able to jump in and offer that as an accessible way of reaching out and getting some support from a mental health professional for people who are interested in that. And sort of concurrently, we've been trying to provide some resources for our mental health provider community to help them get started in case they're very new to this service delivery mechanism, because it's a little bit of an adjustment process, both for the patient and for the provider who would be engaging in that transaction. We've really been facilitating the dissemination of information about wellness apps. So there are a number of applications that folks can get on computers or phones. If you're not interested in a traditional therapy type of a discussion, but you're interested in maybe some self-help types of opportunities, there are a number of platforms that are available for that, which are great. A number of them are being offered for free. In Utah, our state has enabled access for 60 days for free for state residents to be able to engage with that application and get some support for whatever needs you might want to identify through that application, which is great. We've been looking at centralized resource lists of mental health services, including crisis services for folks who are really under a lot of stress and feeling sort of like they need some immediate support. And then we've also got like a warm line, for example, for people who just need to connect with somebody but aren't really quite at a crisis stage yet, and trying to make sure that the information about how to access those services are out there. Our local United Way 211 is a central referral hub for us for mental health services in Utah, also for substance abuse services, which is another area of concern because people who are, particularly people who are new or newer in their recovery, in addition to people who are still working into recovery, getting access to those services is again being interrupted. And I've noticed that NA and AA have taken a number of their meetings online, which is great. And it's great if you have the ability to be able to connect online. But we're seeing innovation pop up. But 211 also has a centralized repository of resources for substance abuse services, for mental health services, and then also for social needs. So if you're feeling really stressed out and you need to connect with somebody, and part of the reason that you're stressed out is because you're worried about putting food on the table for your family, a call to 211 can kind of help assess all the different needs that you have and help you prioritize what you need to be connected to and make those linkages for those assistances through community-based organizations. A number of coping tools and resources we're seeing coming out, trying to make sure that that information gets disseminated to our providers, to our general community. Also really, really worried about our care providers, both our home care providers and our professional care providers, because people who are working in crisis mode day after day after day, taking care of people, at some point that cumulative stress and trauma is going to catch up. And so I see reports about a second wave, mental health being a second wave of COVID. I'm not sure if it's a second wave or if it's a concurrent wave, but I think it's definitely going to catch up with us. And I think the other things that we're really worried about too has to do with people who are losing family members during this time, whether it's due to COVID or not. Our ability to engage in our traditional grieving rituals in terms of funerals and wakes and viewings and just coming together, those are all impacted in this time. And so there's a lot of concern about how those long-term impacts, I think, are going to be showing themselves in our communities going forward, which is why it's good that we're trying to kind of get our resources mobilized and accessible as much as we possibly can now. But I've also seen some great innovative opportunities for sort of organic support to emerge through, for example, we have an application in our neighborhood called Nextdoor, where people can join sort of a listserv and share information. You know, in typical world, it's just sharing information about the neighborhood. But I've seen where those applications, those platforms are being used to connect folks in a neighborhood who want to help their neighbors and folks who are maybe homebound and can't get out to get their pharmacy prescriptions filled or need food or whatever. And people are coming together to sort of offer those supportive connections. And I think that helps not only the helper, but that also helps the person who is looking for someone who can kind of help them out during this time of need. And so those kinds of organic connections coming up, I think, are going to help us through this process as well. So that's just a little bit about some of what we've been seeing so far. And
Kimberly sent me some updates to this slide, and I actually ended up with 2 slides. So you guys can vote which one you think is the more beautiful of the 2. But I wanted to ask Joan, who has a background in psych nursing as well as being an RN and a social work degree, along with being executive director of our friends at CoMagine Utah. Joan, a number of individuals that we have talked to in this group, as well as on a broader basis, have people who are currently co-quarantining with them, co-isolating with them, who have extreme behavioral health needs. And do you have any advice to those who may be dealing with a disruption of what had been a therapeutic routine, or maybe moving back in or something like that?
Thank you. That's a really good question. And I believe that is going to be a real stress point. As we're all quarantined, the reliance on telehealth becomes more and more important. And I believe we're actually going to be talking about telehealth later in this session, and ways that patients can give feedback to providers to make it more meaningful. But yes, that is going to be a stressor for those with chronic mental health conditions. Accessing your local crisis intervention lines for resources, ways to connect. And then I guess if things get that bad, You know, it's always, you know, there is resources, you know, in the emergency department, but that's going to be our last, hopefully, step. But I know there's a lot of interventions going on right now to really make those connections, particularly with those with severe and persistent illnesses and their caregivers through telehealth to keep people supported and stable in their homes. I am going to ask Kimberly to comment. Kimberly is our subject matter expert on behavioral health in Comadgen Health. She's an LCSW and has a degree in analytics. But Kimberly, would you like to add some comments to that question too?
No, I would just adding something into the chat as you were speaking, Joan, where, you know, hearing too, for example, folks who have been maintained on particular regimens that required regular contact with providers, for example, folks that have severe and persistent mental illness who have been maintained on injectable medications, finding that sometimes those regimens are being interrupted because the ability to have contact, regular face-to-face contact with a medical professional for purposes of receiving the injection are being adjusted, and folks are being moved on to oral meds instead for safety. You know, obviously we want to try to minimize exposure, but I think, you know, the impact of that is yet to be seen. I realize it's sort of a harm reduction approach, but I'm not sure that we've seen, you know, exactly how much that's going to help versus hurt in the long term.
Thank you, Kimberly.
Well, those are really great responses. And I'm wondering, amongst our members, I know there are some who have individuals in their home isolation situation who have special needs. If that you're seeing any specific challenges or have any hints for how to cope. Anybody?
Lisa, can I share?
Yes, Diane.
This just recently happened to my mother-in-law. She lives in assisted living, and there was discussion in the family whether we should leave her in the assisted living or if somebody should bring her home during the social distancing, self-quarantining phase of COVID. And we decided to let her go out and live with her daughter, who is single. And so it was a good fit. They had each other to be companions with while they're social distancing and so forth. And she moved out of the, well, she didn't like move out. All of her stuff is still there. She just packed an overnight bag and went to her daughter's house on March 18th. And it was right before they decided to close all the care centers to visitors. It was like the day before or something. And we were so glad that she was out, that she had the opportunity to socialize and go for rides. And, you know, even if it was just with her daughter. And then we realized, we got the statement for her next month's rent payment at the care center, at the assisted living center, and discovered that her long-term health insurance, who pays the majority of the fee or the rent there, did not pay what they usually pay because the care center sends a report in at the end of the month of how many days each person was actually in the facility. And so because she was not in the facility for half of the month, they only paid half of that what they usually pay, which left her with a huge portion of her lease or rent, I don't know what they call it in that situation, to pay on her own, which she doesn't have. Because assisted living facilities are very expensive places to stay. And if you don't have some kind of means behind that, like her long-term care insurance that's paying for that, she's up a creek. Where the family is kind of like jumping in and rallying around her to help make sure that the expense gets paid. But in the end, the decision was to take her back to the care center, and now she's isolated in her room and can't socialize with anybody. So that's been our family's experience currently.
Wow, I hadn't heard that one, and that's one to sure look into further. So we'll have to talk offline a little bit more about that one. I'm noticing, by the way, that there are some. Yes, Joan.
Lisa, this is Joan. Thanks for sharing that, Diane. Diane is one of our wonderful patient advisors in Utah. And that situation really concerns me because obviously you made that call with the best interest of your mother-in-law. And I would try and appeal that decision. I know there's appeal rights. I think this is a special circumstance with COVID-19. And I think there's precedence too. I know the state Medicaid program in Utah is actually paying facilities with that don't have a patient in a COVID-19 bed just to keep them available. So let's talk offline, but I would appeal that. And it seems like insurance companies, need to have a little bit of different eye to this criteria, given this special circumstance with the bio outbreak. Thank you.
Boy, Joan, thank you for that on-the-spot help and an example of what can happen when you get with the right people. So thanks so much, Joan. I asked our advisor, Rachel Weisberg, to just take a minute and talk a little bit about something whose prominence as an issue has really risen to the fore with this COVID-19, but it's something we probably should have been thinking about before. Rachel, can you talk a little bit about advanced directives and post orders?
Sure. Can everybody hear me?
You're on.
Okay, great. Hello, everyone. Well, I have to say that probably most of you have more experience with advanced directives and post orders than I do, because I haven't actually had a personal experience with either of these yet. But so I'll just give sort of a brief 101. An advanced directive is a legal document in which a person, designates their healthcare proxy. Usually it gives, an opportunity to list, 1, 2, 3 different people who you want as, your first, second, and third choices of people who would be making decisions for you if you are incapacitated and no longer able to make decisions about your medical treatment. And then, things like, do I want, when do I want care stopped for me? When do I want to be DNR? How much pain management do I want versus, do I want pain meds to the point where, they would risk my life, or, do I want, sort of like, what are the choices and which one do I want around sort of pain management at the end of life and those kinds of things. So it's always good to do some research before you complete an advanced directive about end-of-life treatments so that you can be really specific, just so that doctors have more clear direction. And then make a lot of copies. You have to have several signatures on those. The signatures cannot be from anyone who has an interest. So they can never be from someone from a healthcare facility. They can't be from someone in your family or anyone who's getting any part of your estate, which is a good thing. And then just make sure that they're kept in a safe and accessible place so that, people can find them if you do become incapacitated. So every adult should ideally have an advanced directive. A post form, on the other hand, is a medical order for the specific medical treatment you want during a medical emergency, but they're usually just filled out by people with frail people in medical situations where they're expected to have a medical emergency. So they're usually just filled out by people who are older, who have specific medical conditions like heart conditions, you know, in which it would be not unlikely to have, you know, a 911 call sometime in their near future. My mom is a caregiver for people in their later years of life, a lot of people with Alzheimer's. And so she's made many, many calls, 911 calls. And often the first thing that they ask before they come and even to respond to the call, they'll say, do you have a pulse order? Do they have a pulse form, and is it accessible? That's the first thing that they want to know. So that's the difference between two of them. For advanced directives, I was just going to say one more thing, which is that it is good with advanced directives to make sure that you have a state-specific advanced directive. You can go to the National Hospice and Palliative Care Organization's website to get your state-specific advanced directive. I mean, there are multiple places you can go to get one, but that's just one easy place to make sure that you're getting the one that is specific to your state. Some cross state lines and some don't, so it's just something to think about. Different states call pulse different things, but they're all pretty much the same thing, but it's just something to think about. So if you make one and then you move to a different state, it's always good to make another.
So that's one thing that patient advisors can do, both for yourself, your family, and recommend in your community that individuals have these advanced directives or pulse orders and I know that this is the current topic for Eileen Karina's Take Charge campaign in upstate New York, or not upstate, Long Island, New York. And Eileen, maybe you could mention briefly what that is, and in the chat, if you would be so kind as to type in the link to your Take Charge campaign.
Sure. Thank you, Lisa. I'd love to. So the Take Charge campaign is basically a campaign grassroots before you get into the hospital or into the healthcare system to recognize 5 steps to becoming more involved in your care. And each month from April through August, we'll be focusing on one of the steps. And April is the advanced directives. And the things we're finding out are really very unique and interesting. College students have never heard of an advanced directive, and yet most people think that their parents will come and help them and have all rights to them. So the information, we're hoping people will follow on the Facebook page and share information, because you never know when one story will trigger someone else to get involved and do their own advanced directives. So we're encouraging people to share a 1-minute video about their own experience. And I will definitely put the information. So please follow it on Facebook. We're not asking for anything other than to share the information. So thank you for that.
Great information. Eileen is doing amazing work. And Chrissy, you have your folks at the UH in Cleveland doing work on advanced directives and pulse orders too, right?
Yeah, we actually a couple of weeks ago launched our vision at UH is advancing the science of health and the art of compassion. So what we've done is put a task force together of maintaining the art of compassion during COVID. We have various patient family advisors, people from EAP, physicians, palliative care, patient experience, spiritual services that are part of this task force. And we're leading a lot of efforts around to support, to unify, and to connect. So leveraging technology. We've already had 500 iPads donated across the system for connectivity for non-COVID patients as well. And then one of the things that we're doing is we put a document together called Be Prepared. We're waiting approval from our unified command, but it does offer some, the link to prepare for your care from UCSF, and to what Rachel was saying, that you can also find your state-specific advanced directives, but also looking at this as, you know, for COVID, this isn't like you've had a long-term illness and you have time to think.
Right.
It could be a matter of hours. So we've really broken down that document. I'm happy to send it to you, Lisa, once we have it approved for quick reference for patients.
That would be great. We'll put it in our newsletter and send it out to our friends at Comagine too. Thank you so much, Chrissy. You're doing such great work there.
Thank you.
I asked our friend Janice Tufte in Seattle to share with us a little bit about the social determinants of health, because Janice does a tremendous amount of work there with our homeless and disadvantaged community, which, by the way, is volunteer work for the most part. And Janice is just an amazing patient advisor from Seattle. Janice, can you tell us a little bit about what social determinants of health are and how people can get the help they need and support others at this time? Janice, are you on mute? Not hearing Janice. I know she was on the line. We'll come back to Janice. But I'm going to ask Morris real quickly to tell us about how the Senior Center has stepped up for sharing meals. We talked about it right before we started recording.
What is it that we're interested in?
Yes,
Hello?
I'm talking to you, Morris. Yes.
Yeah, hi, Morris Wells. I've been involved with Salt Lake County and senior centers for, going on 20 years. I'm on the Nutrition Council. We have 17 senior centers in Salt Lake Valley. A couple of those are run by the cities. Murray City runs one, and then there's one that's kind of halfway between West Valley and Hunter. But at Salt Lake County, they prepare between 2,500 and 3,000 meals per day. Those meals go to Meals on Wheels people, as well as to the senior centers. During this, the Meals on Wheels are still being delivered, but after a couple of days of the kind of shutdown, when the senior centers were shut down, they started providing those same meals to people who sign up and can come to the center to pick them up. So I live between two of the centers, and I go to one or the other depending upon what else I've got, what other errands I have to run. But that's a good opportunity for seniors, and it keeps some people at the center sort of employed. I'm not sure what else they're doing, but we're just kind of holding our breath waiting for this to go away. But I think it's a very successful program. The people that are participating in it like that. The meals are good, nutritious meals. So if you have a decent breakfast and you have one of the meals that they provide at lunch, then you probably have close to your daily nutritional requirements that have been met. And if you just open up a can of soup for supper or make a sandwich, you don't have to feel guilty that you aren't eating well.
Boy, Morris, that is so important. And thank you so much for sharing that. I know that is available in communities around the country. I know in New York City, they are offering meals to whoever wants one at a number of different places. So I think that is something to explore in communities. Janice messaged me that she had an internet challenge, but that she was back on the line. Janice, are you with us?
Yes, I am. I'm sorry. This is a social determinant of health issue, actually, but this is a perfect example. I found out that I was able to apply for a $9.95 a month Wi-Fi internet, right? I was paying $50 a month. And so I was at this, what we call as Community Technology Equity Board meeting, and they said, we want to talk to somebody that's really taken one of these lower priced, lower Mbps services. So I said, well, I'll sign up. I'll see what it's like. And I've stuck with it. And today's one of the first times I've started having problems. And yesterday but I've been on it for months. So basically, the social determinants of health, this is just one of the many. Today, Wi-Fi is really a big issue, or internet. Not only do many parts of the country do not even have it, but individuals don't have, we have mentioned about tablets. They don't have funding to have a smartphone or a tablet. And in this time of telehealth that CMS is now reimbursing for it, this is, there's never been a more important time for internet as well as affordable phones. So social determinants of health are factors that can impact your health in a negative way and create disparities. It's like housing insecurity, food, nutrition insecurity, as Morris just mentioned, social isolation, transportation issues, and really how some of my friends call it is just life, right? So if you're lower income and or you have multiple chronic conditions or you're from a marginalized community, you can face many more of these, what they call social determinants of health, or I like social probabilities of health. But they definitely have a large impact on our lives. And you've probably all read recently about how social isolation actually they know can have a bigger impact on individuals' life than some of their health, what we would consider actual health chronic diseases and or say transportation. So it's very interesting. And now that we're in this period of social isolation, the individuals that were experiencing, depression, loneliness, it's actually loneliness, right? That were experiencing loneliness, how are they now, right? So there's quite a few lines. I'm not sure if you're aware of the Friendly line, I believe it's called, and Aging National Institute on Aging has it. It's called the Friendship Line. Actually, I think it's a 24/7 line. Maybe it's just a day line, but it's on and where anybody around the nation can call individuals that are older and or have disabilities or challenges. And so it's just to talk, just to talk to somebody. So there's a couple of those that are going on, but I wasn't aware of that until my friend volunteered there. And so I think this is something, these are type of resources. When you had asked earlier, what can we do to compensate for the social isolation and loneliness? Because in the long run, I think we're going to have a lot more people with issues in the social determinants of health, even if you have a housemate or a spouse and or you have a nice home, it doesn't make a difference if you're socially isolated and lonely. You're still going to have a higher opportunity to have more of a worse or poorer health outcomes because of that. So basically, addressing the social determinants of health are challenge, and it's kind of state by state. You can go to 211 and there's other ways to access them.
Could you, what was the name of that line that you mentioned that you can call? And
Friendship Line.
Friendship. Can you put information about that in the chat, please? And is that aid for Wi-Fi specific to Seattle, Janice?
No,
I noticed that Joan was asking.
Nationwide. It's by the National
Nationwide.
Institute on Aging.
National Institute on Aging. Okay, so if you could either chat in that contact or send that to me, and I can pass that on to Joan as well. Thanks so much, Janice, for taking the time to do a little bit of research and share that with us.
Also add discounted Wi-Fi and phones for all the states. There's one site for all that.
Oh, okay. Good.
Yeah. Okay. Thank you.
Great to have those resources. I wanted to talk a little bit about, we had identified when I sent out a question to our advisory panel, some different areas of concern. And one was how to support not support, but advice to our healthcare providers around supportive communication, how they can support us. And I was hoping that Jody Hanson could talk a little bit about something I've heard her mention before, that is the importance of hope. Jody?
Yeah, thanks. So, I mean, we all know that we need hope, during this whole craziness. That's kind of what keeps us going, knowing that we're not going to continue this forever, that we'll be able to, at some point, leave our homes and feel safe. But when we're in the hospital or we're getting news, it's really important to give hope. As providers, it's important. It's not just important, it's essential that our families have hope, because if we don't have hope, then we give up. And once we give up, then that's not going to be healthy for the person that's needing the care. And so hope has brought us through many times. My son Jacob has cystic fibrosis and cerebral palsy, and there's been times that we've wondered if he would make it through the night. And it's been important for us to have some type of hope. And I kind of haven't understood why providers are sometimes a little bit skeptical of that and worry about giving too much hope. I don't think you can give too much hope. You as providers live on hope as well. You have your education, but you're hoping that your patients are going to make it as much as the parents are. And so give a little bit of that hope to the families and the patients. It just is very, very important.
Boy, thanks so much, Jody. And you always have such wise words. I appreciate that so much. Diane, I asked you if you would talk a little bit about the importance of giving a choice, maybe even when it doesn't look like there are choices to be made.
Sure. I think that one of the biggest benefits of having choices is the feeling that you're in control of what's happening to you. And I think that also feeds into what Jody said about having hope, is that if you feel like you have some sense of control of what's happening, then you have a feeling of hope that things are going okay. There's an experience that my daughter had when she was in treatment for leukemia. She had experienced several infections that left her wasting away, and they needed to begin a refeeding program for her because she wasn't eating, and her body was no longer taking whatever she took in as nutrition. It wasn't doing anything with it. So her doctor was so very kind and patient with her, and he came to her and gave her the choice. I mean, she was only 9 years old, and he said, we need to put a feeding tube in to get food into your stomach that it can eat. She had been on IV feeding for about 3 days, and he said, but you can choose. We can do it now. We can do it today before I go home, or we can do it tomorrow. And she was a little perplexed, but he said, it's okay if you're not ready to decide right now, I'll come back and check on you. And he did. He came back at the end of the day. It was after 5 o'clock. Then, I'm sure he'd finished all his stuff for the day and was ready to go home. And he stopped back at the room and asked her again, do you want the feeding tube today, or do you want it tomorrow? And she said, today, if you do it. Bless his heart. So he did. And he took her into a separate treatment room so that the experience, however traumatic that it can be and was for her, that it was not associated with her patient room where she was recuperating. And small choices like that, you can choose now or you can choose later, but it still has to happen. It leaves the patient with a sense of control of what's happening to them and when it happens and how it happens. And I think that feeds into the hope. The whole point of wanting to get treatment is your hope of getting better.
Boy, thanks, Diane, for that. And it does feed into hope. And I've heard you share that before, which is why I asked you to share it. There's others on the line who know our friend, Dr. Nate, who handled that so gracefully. And
Lisa,
was so important to you.
Lisa, we have a comment in chat that I think is very important for Jody
Yes,
and
I was just going
Diane
to get to
to
that. I was just,
address. Okay, well then go. Go
yeah.
for it.
My colleague Marty Hatley has asked Jody a question. Marty, do you want to verbalize that?
Sure. I think, I mean, Jody, your question, your comments about hope really resonated with me. And I think one of the worries that providers have is they don't want to create false optimism when that things are going to get better, sort of unrealistic hope. I mean, I don't know if I'm picking the right words to describe it, but there is some fear there, some hesitancy that you picked up on and I've seen too. And I'm wondering how you maintain hope when we know that we're going to be in something for the long haul. This just came up as a question from a provider on a webinar, and I didn't have an answer.
Yeah, so I think, it's hard to have that balance, I think, for providers. I think they feel like they need to prepare the person. The reality is, you can't really prepare for somebody to feel the feelings that they're going to have if there's death or if there's, a disability that happens or something. You can kind of warn them, but until they're actually in it, they're not going to feel that. And I think that you can say, these are some of the things that we see or have seen in this type of situation before. For instance, when my son, we thought that he would probably have cerebral palsy. He got, I can't think what it's called. Anyway, they said there are some things that we have seen happen with this. Spinal meningitis, sorry, I don't know why that slipped my mind. They said, we sometimes see people who you would not have any knowledge that they had the spinal meningitis, and then we've seen people who it has really affected, and we've seen everything in between. And they kind of mentioned what could happen, but they also gave us some hope of what also could happen. And I think that as patients and families see that hope, they hang on. They keep going, where if they feel like it's all doom and gloom, they give up. And sometimes I think patients give up to the point where, they may not have passed away, but they did because there wasn't that hope there. I don't know if that answers your question or not.
Well, it
Right,
helps.
thanks a lot, Jody.
Yeah.
I think Eileen may have a comment related to that. Eileen? Eileen, are you on mute?
There I am. Yep, I was looking for my mute button. I only wanted to bring up that when we talk about this, we usually do talk about death and dying, and it doesn't have to be about end of hope or everything. When we talk about this, it's really about even very, very temporary. Our college students who are working on this are studying the Terry Schiavo and Karen Ann Quinlan cases. They're too young to remember that. And the history of advanced directives and things that can happen and go wrong. And those two women were very young when this happened. So I just wanted to throw that out there that, again, a temporary, this could all be temporary. And I think if we keep thinking about it as end of life or a negative, it really doesn't have to be a negative. And that's for families. The providers, of course, I can't talk for providers, but as far as family or somebody who works with families, it doesn't have to be a negative.
Eileen, this is
Lisa,
Mark.
if I may share something from, I'm going to be a patient here, family. When my husband had a very serious illness, and it was a lot of complications from pancreatitis. He was in the hospital for 90 days in 2008. We had an infection specialist, infection control specialist, MD, come and tell him, well, this is so serious, you may likely die in a week. And my husband called me right after and said, are you holding back something from me? Are you not being honest with me? And I think my take on this is really how the provider messages some of this. I think the message could have been, yes, Andy, you have a very serious illness. He knows that, we know this, but he sort of left it like, with my husband, he was going to give up, he, and created suspicion that his hospitalist physician and I were withholding information. So I think, Jody's right. It's like, you just can't dash every hope, but it's how it's messaged. And those messages have to be very carefully and empathetically delivered. It was very harsh. Lisa, I asked for that physician to be removed from my husband's care promptly after that. And his hospitalist was also very upset how that came across, because that was what was getting my husband through, was that pushing to go home and that desire, I want to get out of here. I want to do better. So my 2 cents.
Boy, I appreciate your 2 cents, Joan. That was a hard experience, and I'm sorry that you had that challenge with communication, which is exactly what we were asked to look at, was supportive communication. And I like the way Susan Brown from Iowa put it in the chat, that we want our providers to be gently honest. And Rosie has chatted in some good comments too, that Rosie lives on hope every day. So we've really hit a thread here that's important, is that providing hope in some aspect. And I think even in end-of-life care, when I was working with the end-of-life children's waiver here in Utah, we pointed out the importance of saying that the end of life was not a hard thing, that the passing was not a hard thing for many individuals, and giving families hope in the most difficult of circumstances. So that's something we can explore further going down the line. I think it's obviously an important topic to all of us.
Lisa, can I say one more thing about it before we go?
Of course, Marty.
I think providers also, just because they don't walk in our shoes when we're caregivers, they underestimate what has meaning to us. And they do default to thinking, well, the situation is hopeless from a medical point of view, when they don't really understand that, every conversation we have, or every time we have a good day with someone that, that has some pleasure in it, that's important to us. And I don't know how we teach that to them, but I guess it is empathy. It is just realizing that it's not all about the end result. It's about, having a good day and having an important conversation or a moment. So
absolutely. And, I think also that we teach it to them by doing exactly what we're doing here. Is if we can have more families talk directly to them and say, this is what's important to us, it helps them connect on a more personal level. So I hope we have more opportunity to do that going forward. But thanks for that.
Lisa, yes, Chrissy. I just, one quick thing, hi everyone. I mean, just through all of this and working, well, I'm virtual right now, but connecting a lot more with physicians. And I think that I think palliative care doctors have an opportunity here to work with their physician colleagues around empathy. They do tend to have this, just from what I'm learning, this natural knack of patient and family centeredness. And the one doc that I work with, we could bulldoze an entire field if we needed to. But
well, it is palliative care's venue really to specialize in this, although hopefully the providers all get a taste of how to be supportive in their communication. And I'd like people to notice that Jan has asked an important question in the chat, and if you have feedback for Jan, to share that with her. And Jan, I will follow up with you also later. I did want to touch on briefly that we're seeing a lot of telehealth, and we're getting a lot of questions at CAPS around telehealth. And we only have a few seconds, but I'm interested in your feedback about how it's going for you. Has anybody used it? Have a comment about it?
This is Eileen. I just used it recently, and you're talking about the video, right? Being on video with your
right.
Oh, I thought it was like amazing. I touched my nose and touched my fingers, and I thought it was just great. And I asked to never go back to his office, and he said nope. But I thought it was wonderful, and I think that you know, I guess used appropriately, it's something that we could use. What I'm laughing about is that I keep getting from my gynecologist that they do this, and I keep saying, "But how the heck you do this?" You know. So I think it's a great, I know, right? I think it's a great service because you can get close to the camera, and they can kind of do a little bit of an exam. So I was really thrilled with my doctor.
Okay. Well, if you have input around that, unfortunately, we are at just about the top of the hour, and I did want to get in some other things. But if you have input around that, I'd sure like to hear it. So give me drop me a line if you have that. Your thoughts, Joan?
My thoughts are this has been very, very, very helpful. And one thing I have just noticed, it's been very glaringly apparent, is that I think the patient and family input into this whole COVID-19 crisis has been sorely lacking. And I want to elevate the importance of this on just all of these issues that we've talked about this morning. So what I would like to do is write up some of my notes, some of the key recommendations from this. Lisa, I'd like you to review them. We can get them out to both of our PFACs, but I'd like to actually forward this on to our Medicare contracting officer at CMS. I'd like to share this with the state COVID task force I sit on. I'm going to be rattling some chains based on some input from Jan Lambert, who just added a comment there that, you know, we need to have patients involved in some of these strategy sessions. It's just been sorely lacking. And I don't think it's nefarious, the intent, but this isn't just a provider crisis. It's a patient total crisis, and you know, the social isolation, the depression, the anxiety that Kimberly emphasized earlier. We need to deal with this in a very holistic manner, and it's just my 2 cents that this has been lacking. So this is what I plan on doing in the future: is elevating these comments to higher levels, so our policymakers can be reminded of the importance of this. Thank you.
Thank you. Are we done?
We can't hear you, Lisa.
We're almost done. I want to thank everybody and thank Joan and appreciate her willingness to elevate this to policymakers, and we will be sharing with individuals nationally that we meet with as well. We wanted to leave you with some additional resources that will be available, and we will send these out to both groups. CAPCI has a good toolkit that includes supportive communication. AARP has a number of toolkits. There's information around helping patients stay connected to their loved ones from Becker Hospital Review. Wired had a story on using iPads at this time, and we have a COVID guide from NAMI, as well as the CDC's use of masks, which is new to all of us. And want to thank you for being with us today. You can reach me at lisa.maurice@gmail.com or through our website, patientsafety.org. And Joan can be reached at jgallegos@comagin.org. And the Comagin website is comagin.org. So thank you so much. Thank you to everybody who chatted in a comment. Those have all been captured, and we will get back to you as necessary. Appreciate everybody participating. As always, patients know best, and we will hope that everybody stays safe. Take care.